Hello, today we are going to discuss about erythroblastosis fetalis, which is also known as haemolytic disease of newborn. Before we through the topic, there are terms that you must understand in order to progress further. The terms are agglutination, agglutinins, antigen, rhesus factor and phagocytosis. So, assuming you know these terms, let us study this disease. The textbook definition is that erythroblastosis fetalis is a disease of the fetus and newborn child characterized by agglutination and phagocytosis of the fetus's red blood cells. The meaning is the red blood cell of the fetus is phagocytized and destroyed. How it happen? Let me explain the pathophysiology with a situation. In most instances of erythroblastosis fetalis, the mother is Rh negative and the father Rh positive. By the law of independent assortment, the baby has inherited the Rh positive antigen from the father. Now is the important part to be remembered. Fetus is considered as foreign entity and as a result the mother's immunity system will try to destroy this foreign entity. Remember this concept. Because of this, mother develops anti-Rh agglutinins from exposure to the fetus's Rh antigen. The mother's agglutinins diffuse through the placenta into the fetus and cause fetus red blood cell agglutination. Easy, right? When we talk about the incidence, Rh-negative mother having her first Rh-positive child usually does not develop sufficient anti-Rh agglutinins to cause any harm. So, the first child is saved. However, about 3% of second Rh-positive babies exhibit some signs of erythroblastosis fetalis and about 10% of third babies exhibit the disease, and the incidence rises progressively with subsequent pregnancies. Let us now see the clinical features. You already know the pathophysiology. Continuing from the agglutination of the fetus's red blood cell, these cells subsequently hemolyze, releasing hemoglobin into the blood. Then, the hemoglobin are converted by the fetus macrophages into bilirubin. Excess bilirubin causes the baby's skin to become yellow, which is also known as jaundiced. This is not the end, the antibodies can also attack and damage other cells of the fetus. The jaundiced newborn baby is usually anemic at birth, and the anti-Rh agglutinins from the mother usually circulate in the infant's blood for another 1 to 2 months after birth, destroying more and more red blood cells. The hematopoietic tissues of the infant attempt to replace the hemolyzed red blood cells, so as a result the liver and spleen become greatly enlarged and produce red blood cells in the same manner that they normally do during the middle of gestation. Because of the rapid production of red cells, many early forms of red blood cells like the nucleated blastic forms, are passed from the baby's bone marrow into the circulatory system, and it is because of the presence of these nucleated blastic red blood cells that the disease is called erythroblastosis fetalis. Although the severe anemia of erythroblastosis fetalis is usually the cause of death, many children who barely survive the anemia exhibit permanent mental impairment or damage to motor areas of the brain because of precipitation of bilirubin in the neuronal cells. This condition is called kernicterus. One treatment for erythroblastosis fetalis is to replace the neonate's blood with Rh-negative blood. About 400 milliliters of Rh-negative blood is infused over a period of 1.5 or more hours while the neonate's own Rh-positive blood is being removed. This procedure may be repeated several times during the first few weeks of life, mainly to keep the bilirubin level low and thereby prevent kernicterus. By the time these transfused Rh-negative cells are replaced with the infant's own Rh-positive cells, all the anti-Rh agglutinins that had come from the mother will have been destroyed. When we talk about the prevention, we have to identify the culprit and destroy it. The D antigen of the Rh blood group system is the primary culprit in causing immunization of a Rh-negative mother to a Rh-positive fetus. An anti-D antibody, or also known as ROGAM, is administered to the expectant mother starting at 28 to 30 weeks of gestation is the main prevention of this condition. The anti-D antibody is also administered to Rh-negative women who deliver Rh-positive babies to prevent sensitization of the mothers to the D antigen. This greatly reduces the risk of developing large amounts of D antibodies during the second pregnancy. The mechanism by which Rh immunoglobulin globin prevents sensitization of the D antigen is not completely understood, but one effect of the anti-D antibody is to inhibit antigen-induced B lymphocyte antibody production in the expectant mother and interfering with the immune response to the D antigen. As usual, there are quiz questions. Pause this video and answer them. Comment your answers below. As usual, please like, comment and subscribe if you find this video useful, as this will motivate me into doing more videos like this. Don't forget you can request your biology or medicine topics via the Google form that is linked in the description below. Thank you and see you all in the next video.